Hello, dear friends. I am Dr. Prateek Sharma. I am your friend, and I am here because I understand the pain of preparing for the exams 1 to 2 months before. So, I am here with a few topics that are really going to help you in your preparation. And if you are able to recall these topics and just remember them on your fingertips, then they are definitely going to help you. One of my teachers used to say, करत करत अभ्यास के जड़मति होत सुजान रसरी आवत जावत के सिल पर परत निशान. So the thing is, even a simple rope can make mark on the stones. So even if you have tried and not succeeded before, still if you persist, you are definitely going to improve and perform at your best during these exams. So today we are going to discuss stroke, and let us learn it with a question. So a lady, just a second. A 68-year-old male was brought to you with history of sudden onset headache and difficulty in using left upper and lower limbs since past 40 minutes. He was stuporous and BP was 190 by 120 millimeter mercury. Power in left upper limb and lower limb was 2 by 5. See, the thing is, what is good about family medicine exams is you are going to find answers in the questions only. Before going at the parts of the questions, you just have a look at the clinical scenario. The patient is 68-year-old male, history of sudden onset headache, okay, and difficulty in using left upper and lower limb since last 40 minutes. So this is acute onset. BP was also high and power is decreased. So what do you suspect? This is definitely stroke. Okay. And which stroke? You guess this. Just pause this question, pause the video, just have a look at the all the ABCD parts, then we are going to discuss it. Pause now. Let's start again. So question A is of 2 marks. And what is the examiner asking? Clinical diagnosis in this patient. And then the causes of CVA. Okay. He is asking the clinical diagnosis. He is not asking the final diagnosis. Okay. And in the next one, he's giving the answer also, cerebrovascular accident. In part B of the question, he's asking to differentiate between thrombotic and hemorrhagic stroke. So now we have the causes which he wants us to elaborate. Thrombotic and hemorrhagic strokes. Then in the C part, he wants to ask CT findings of hemorrhagic stroke. Now he's giving the final diagnosis also. See, in part D of the question, he is asking, now this is where you need to know the guidelines. He is asking, what are the indications of thrombolysis and what are the guidelines for administration of recombinant tissue plasminogen activator. This is of 3 marks because this is a technical question. Everything is technical, but these 3 questions you will be able to answer easily. But in this, you need to apply your brains. So what is the clinical diagnosis of the patient? Acute cerebrovascular accident. Simple. Now, just while you write the diagnosis and mark it. Remember, write in bold. Don't write in paragraphs. Write in bold points and bullet points, and mark where you want the examiner to have a look. Just underline it and write relevant. Don't write to fill the pages. You just have 5 sheets for this question. Okay. And this is right-sided stroke. Why? Because the hemiparesis was left side. Now you can tell why you went with the diagnosis. This is sudden onset with headache, high blood pressure, unilateral weakness. Okay. Then what are the causes of CVA? One is ischemic and the second one is hemorrhagic stroke. What are the causes of ischemic or ischemic stroke? Ischemic stroke. It can be thrombotic or embolic. Thrombotic because sometimes due to complications of certain chronic diseases like diabetes, the blood vessels form the thrombus. Embolic, there might be some cardiovascular events like in atrial fibrillation, where the heart is not pumping. There is high tendency to form clots. So the clot may dislodge and go into the artery of the brain. And the first one is atherosclerosis, cardiac embolism. In certain, when the patients undergo valve replacements, also mitral valve replacement or aortic valve replacement, these have a high tendency to form clots in the heart. So that may also dislodge. Then the third one is small vessel disease. You must have seen many times lacunar infarction mentioned in the CT or MRI reports. Then the second one is hemorrhagic stroke. Hemorrhagic stroke is because of hypertension. There might be aneurysm rupture, AV malformation, trauma. In see, in all these cases, in all these cases, the vessel wall is getting compromised. The vessel wall is getting compromised. In this one, there is high tendency to bleed, coagulopathy. When the patient has undergone wall replacement, so what we start? We start the patient on blood thinners. We may start with this azithromycin, warfarin, those stuff. Then the patient we have to monitor the INR of the patient. Then the coagulopathy may result into hemorrhagic bleeds. Now, next part is how will you clinically differentiate between thrombotic and hemorrhagic strokes? This question is of 3 marks. So, write relevant points and explain with the help of classification. So, onset, in thrombotic stroke, it is usually gradual onset. The patient, the patient might wake up and is unable to walk when he is trying to go to urinate. In hemorrhagic stroke, it is sudden onset. It usually occurs with severe headache. Okay. In blood pressure, in thrombotic stroke, it is usually normal or elevated. In the hemorrhagic stroke, it is really, really highly elevated. Hypertensive emergency. In symptoms progression, the symptoms of thrombotic stroke may progress over hours to days. And here, hemorrhagic, it is the symptoms are severe in intensity and are sudden. Consciousness, the patient might remain alert. Here, the patient might go depressed in consciousness. And in headache, the next point is headache and vomiting. It is less common here and it is very common. The intracranial pressure raises, which might result in headache and seizures. And also, the patient might have a tendency to pass motions, stools, and urine. Okay. Then there might be history of TIA in this one, thrombotic stroke. Whereas in hemorrhagic stroke, there is no prior history. Then what are the findings on CT for a hemorrhagic stroke? This is of 2 points. Write relevant. If you even just write 2 points, then you are definitely going to score good marks. Just write a point, highlight it or underline it, and just write an important point along with it. Hyperdense area in hemorrhagic stroke, the what happens in ischemic stroke? The area appears black, whereas in hemorrhagic stroke, it is hyperdense area or the white area. And there might be midline shift, mass effect. There might be ventricles might get compressed and there might be surrounding edema. Okay. Now it is an important question. What are the indications of thrombolysis? And what are the guidelines for administration of recombinant tissue plasminogen activator? See, usually thrombolysis is done under the guidance of a neurologist. But if you are in a peripheral center, and and you're confident, then definitely you can do it on your own. Here I'm going to discuss the guidelines. If the onset of symptoms is within 4.5 hours, then it is an indication. If the age of the patient is more than 18, then it is an indication. The findings must be confirmed with CT, because you have to rule out hemorrhagic stroke. Okay, to differentiate between thrombotic and hemorrhage is difficult on clinical examination. So unless you rule out with the CT, uh, we usually don't go with the thrombolysis, and you must have made clinical diagnosis of stroke, or there must be hemiparesis or aphasia. Then what are the guidelines of RTP administration? Initial initial evaluation, you have to go with NCCT, emergency. It is an emergency, and you must undergo emergency CT scan, NCCT head, to rule out hemorrhage. Then you must undergo blood glucose testing. You have to correct the hyperglycemia, because correcting hyperglycemia might help patient get better soon. So check the sugars and correct it, and check the coagulation profile. Check whether the PTINR of the patient is normal, platelet count, and other tests. Then you have to control the blood pressure. It must be less than 185 by 110 millimeter of mercury. What are the exclusion criteria? The patient must have not undergone any surgery in last 14 days. There must be no trauma history in the past, acute trauma history. The hypertension must be controlled. If there is a history of hemorrhagic stroke, then you don't have to give it. Check the PTINRs and coagulation profile and platelet count. If there is MI or GI bleed, then that's a contraindication. And check for any bleeding diathesis, and any active bleeding. Then how to administer recombinant tissue plasminogen activator? You have to secure two peripheral IV lines, gray or green cannula. Then you have to avoid central line. Check the eligibility of RTPA. Previously we have discussed. You have to administration. This is a dosage, 0.9 mg per kg IV. Maximum you can give 90 mg, and 10% is given by bolus, and then remainder is given with IV infusion over 1 hour. Nowadays, usually tenecteplase is preferred, because you can give it as a bolus dose over 5 seconds only. Check the BP frequently. There must be no antithrombotic treatment for 24 hours at least. And if the neurological status declines, then go for NCCT scan again, emergency. And also we have to give cryoprecipitate to stop, uh, to help in the uh, stoppage of, if there is any bleeding. Avoid catheterization, because it might lead to hematuria, and it might injure the urethral tract. So you should avoid any injury during this phase. Also, friends, uh, as a consider me as a friend, and it is important for me to uh, support you at this crucial step. And just remember, karma is in our hands. The work is in our hands, and if you do the work properly, if you enjoy the journey, then definitely the fruits are going to be great. So all the best. See you soon.